Neurology Forum, which we started just to promote presentations by postgraduates as well as faculty from all parts of the state, and to have chairpersons from all faculty in the Tamil Nadu state. So with this motto, we are in the 22nd webinar session. And today I have great pleasure in inviting Professor Alagason, the Professor of Medicine and Neurology, who is the head of the Department of Medicine and who is retiring in 2 days' time. It's a great privilege and pleasure for me to invite him. He has been a good friend of mine. And in spite of being Professor of Medicine and head of the department, he has retained academic interest in neurology and has taken part in several neurology teaching programs. And as I said, it's a pleasure to invite Professor Alagason to take over and conduct the proceedings. Professor Alagason, you can take over. Thank you.
Thank you. So, good afternoon to all. At the outset, I thank my mentor, my teacher, Professor V.N. sir, for asking me to chair this session. And today's session, we have two moderators, Sivakumar, who is holding the HOD of Neurology, Kumaramangalam Medical College, Salem. He's a very good teacher, and we did DM together at Institute of Neurology. And he has got 25 years teaching experience. And we have next moderator, Dr. Thiruvil Chelvan. He is an associate professor of neurology in Government Medical College, Salem. And today we have 4 interesting cases. So I invite the postgraduate Divya to present an interesting case of a neuromuscular disorder, a diagnostic dilemma.
Good morning, sir. Good morning, sir.
Yes.
Shall I start, sir?
Yes, Dr. Divya, you can start.
Good morning, sir. I thank my HOD and Shiv Kumar sir and Professor Thiruvil sir for giving me this opportunity to present in this forum. I'm going to present a case of neuromuscular disorder. Mr. Jaykumar, 22 years old male, right-handed individual, studied up to 10th standard, working in a poultry shop, residing at Rasipuram, has come with presenting complaints of difficulty in getting up from squatting position for 12 years duration, difficulty in lifting left arm above shoulder for 6 months duration. History of presenting illness. Patient was apparently normal till 5 to 6 years of age. After that, he found difficulty in running along with his peer groups. He will halt after running for a few distance. Gradually, he stopped running because he had frequent falls while running. When he was studying around, that is at 10 years of age, when his teacher asked him to kneel down, he found difficulty in getting up from that position. Gradually, his difficulty increased, but he managed to get up with hip up first and hands supporting on the ground and then on the knees. His weakness gradually worsened that he is unable to get up from sitting in floor and support from 15 years of age. Difficulty climb up and downstairs present with support of side rails and keep both feet in a step before he could climb the next step. He is able to climb the stairs. History of difficulty in walking present. His friends and family members noticed his hip tilting to either side while walking. He was able to ride bicycle till his 15 years of age. After that, he found difficulty in lifting his leg to keep on the pedal and also for pedaling. History of difficulty in gripping slippers in both feet present for past 8 years duration, that is from his 14 years of age. History of slippage of slippers from both feet present with awareness. He will either use belt type slippers or not use at all. History of flailness of both lower limbs present. History of buckling of knees and recurrent falls present for the past 6 years. No history of tripping of toes. Initially, he used to take pull-ups until he was 16 years of age, after which he found it difficult and not able to do so. Gradually, he had increasing weakness of both upper limbs in the form of not able to lift heavy objects for the past 6 years duration. Now, for the past 6 months, increased weakness of left upper limb to rise even above the shoulder level. With right hand, he is able to comb his hair, take objects from the shelf. There is no history of difficulty in mixing food, buttoning or unbuttoning shirt or writing. History of difficulty in turning in bed from side to side present. No history of difficulty in lifting the head off the pillow. History of cramps present on and off during work in any of the forelimbs. No history of thinning of muscles, no history of twitching or tremors. No history suggestive of enlargement of muscles. No history of pain at rest or even after exercise. No history of difficulty in releasing hand after handshaking or gripping onto objects. No history of diurnal variation of weakness of the limbs. No history of fatigability or exercise intolerance. No history of worsening of weakness on cold exposure, even after, or no history of worsening after fever or stress. No history of discoloration of urine. No history of difficulty in maintaining erect posture during sitting or standing. No history of difficulty in breathing in supine position. No history of abdominal distension. No history of fever, trauma, toxin exposure, or recent vaccination. No history of chest pain, palpitation, breathlessness, or cough. Coming to cranial nerves, he is able to appreciate smell, able to see near and distant objects clearly, able to appreciate colors, able to look into all directions. No history of drooping of eyelids or double vision. Able to feel the sensation over face and chew foods. Able to close eyes tightly, drink through straw, whistle, blow balloons and candles. Able to hear well, no tinnitus or giddiness. Is able to swallow solid and liquid foods without any regurgitation. No history of hoarseness of voice or nasal twang in voice. Able to turn head sideways and able to protrude his tongue and marshal food inside the mouth. Sensory is able to feel the sensation of cloth, able to feel the pain, hot and cold water while bathing. No history of neck pain, back pain and radiating pain. No history of any band-like sensation, tingling, numbness, pins and needle sensation. No history of incoordination in the dark or feeling the ground like a cotton wool. Or no history of electric shock-like sensation while flexing the neck. No history of any bladder or bowel disturbance. No history of abnormal sweating. No history of tremors, spillage of food or water when bringing to the mouth. No history of unsteadiness or on standing or swaying while walking. No history of slurring of speech or involuntary movements. No history of any altered sensorium, loss of consciousness. No headache, nausea, vomiting, seizures. His birth and developmental history were normal. Past history, he has no known comorbidities. Consumes alcohol once per week. Abuse or high risk sexual behavior. Family history. He is the firstborn of third degree consanguineous parents. No other family members suffering from similar illness. Timeline. He at 5 years of age, he found difficulty in running. At around 10 years, he found difficulty in getting up from squatting position. Around 14 years of age, he found difficulty in gripping chappals. 15 years of age, he found difficulty in climbing the stairs and riding bicycle. From 16 years of age, he had a difficulty in lifting heavy weights in both upper limbs. From that is current 22 years of age, difficulty in raising the left arm above the level of shoulder. Summary. 22 years old male, a firstborn of third degree consanguinity with normal developmental milestones and cognition, presented with insidious onset and slowly progressive weakness of all four limbs, starting from 5 years of age. Initially started in the lower limbs, proximal, followed by distal, flail type of weakness, then bilateral upper limb, proximal weakness, left more than right, with muscle cramps, without thinning or twitching of muscles. Without any family history, without involving extraocular, facial, bulbar or respiratory muscles, cranial nerves, higher mental functions, sensory, cerebellar, extrapyramidal or autonomic nerve system. Shall I proceed with localization, sir?
Depends on the chairperson.
Yes,
And,
yes.
and of course, Sivakumar. What does Shivakumar want?
And it's, I think she can discuss at this stage regarding the professional diagnosis and the
Okay.
steroids.
First of all, Divya,
Yeah.
Yes, sir.
congratulations. It was a very good presentation and a very good summarization. You did very well.
Thank you, sir.
Yes, you can go ahead.
Divya, you can just give your diagnosis at this point of time. What is your thinking?
Yes, sir. Localization after summary, it is a element type of quadriparesis, a pure motor type. First it started with lower limb proximal, then lower limb distal, then upper limb proximal, which is asymmetrical. So at this point, I would like to consider muscle as my first possibility. The points in favor of muscle are, it is a classical phenotype of a muscle disease like proximal more than distal weakness, starting from the age of 5 years, slowly progressive insidious onset. But the point against muscle was the upper limb asymmetrical weakness, which started now. The second possibility I would like to consider is anterior horn cell, considering this asymmetry and progression, slowly progressive. So in muscle, I would like to consider the following possibilities. The first possibility could be Becker's muscular dystrophy, starting from 5 years of age, insidious onset, slowly progressive, and also the pattern of weakness, initially proximal lower limb weakness, which runs for this many years. Second possibility I would like to consider is a limb girdle pattern of muscular dystrophy. In that, depending on the age of onset, the DDs could be sarcoglycanopathy, calpainopathy, or fukutin-related protein muscular dystrophy. Considering the asymmetry, there could be anactaminopathy or dysferlinopathy, but those are distal myopathies. The third possibility could be congenital myopathy, since it started in his early age and is very slowly progressive. Congenital myopathy also I would like to consider. Then last, but I would like to consider is metabolic myopathy, like Pompe's disease. But juvenile Pompe's will start at this age, but second, third decade, they will worsen with respiratory failure or cardiac complications. And one more thing is endocrine myopathy, hypothyroid also we should rule out because it is a treatable condition. In anterior horn cell, I would like to consider the possibility of spinal muscular atrophy. These are my DDs.
Divya, can you say some points which, okay, let me ask you. See, there is no enlargement of calf muscles. There is no pain. There is no breathing difficulty. Cramps are present.
Yes,
no fasciculations. In other words, no twitching of muscles.
Yes,
Do they help you to narrow down the differential diagnosis? Don't pay too much attention to the asymmetry. I agree it's asymmetric, yes, in the upper limbs.
Okay, sir.
But that alone may not clinch the diagnosis. You'll have to have a broader view. So with these points, which I just highlighted, will it help you to narrow down, and onset being in the first decade, as which you already said? Yes.
Yes, sir. Among muscle, which is the first you are asking us?
Yeah, not only muscle, anywhere in the lower motor neuron with these features. You localize to the muscle.
Yes, sir.
Go ahead.
Apart from this, we can consider
No, you continue. You consider the muscle. Finish the muscle.
Okay.
You have listed 4 possibilities. Which would you think with these features which I have said, negative features which are not there, and the presence of cramps?
I would like to consider limb girdle pattern of muscular dystrophy, sir.
That would be your first.
Yes, sir.
Okay.
Yeah,
Allegation takeover, sir.
Yes, sir.
Allegation
Divya, in the lower limb, you also mentioned the distal weakness, isn't it?
Yes, sir. First proximal, then followed by distal.
Distal. And you also mentioned about slight asymmetry
Yes, sir. Upper limb.
in the
asymmetry.
upper limbs.
Yes, sir.
So any other possibility other than the DD which you have mentioned? The history of your muscle cramps.
In muscle, apart from this,
Sir is not asking only muscle. It can be anywhere lower motor neuron. Features are of lower motor neuron because the flaccid tone and the presentation as such. With no family history, onset in the first decade.
okay, sir. We can consider neuromuscular junction also, sir.
Yeah, probably that's what he's leading on to. I don't know.
Yes.
It could be
Is-
congenital
Yeah.
myasthenia
No,
also.
is there a history of any fluctuation of the weakness?
Fluctuation of weakness, sir.
Any diurnal variation?
No diurnal variation of weakness.
Or diurnal variation? Can we think of any neuromuscular junctional problem?
Congenital myasthenic syndrome can be considered, sir. But
Okay.
considering its age of onset from 5 years to 22 years of age without any treatment, he's just slowly progressive, sir. No fluctuation or diurnal variation. No.
That is not against. That is not against.
No, against.
That should also be considered, sir.
Shivkumar, you want her to proceed or you want something else?
Sir, I think we can proceed, sir.
Yes, sir.
Because
Yes, sir.
SMA, she is also considering a possibility, sir. That
Okay.
SMA also has to be thought of in addition to this muscle problem.
Agreed. We'll see the findings.
Okay, sir.
Moving on to examination, general examination, the patient is conscious, oriented, moderately built and nourished, no pallor, icterus, cyanosis, clubbing, pedal edema, lymphadenopathy, no facial dysmorphism, bilateral face cavus present, bilateral EDB hypertrophy present, bilateral hamartos present, bilateral cough prominence present, no contractures, no neurocutaneous markers, no signs of vitamin deficiency, no thyroid swelling, skin is normal, no rash or thickening, no kyphoscoliosis or exaggerated lumbar lordosis, no trophic ulcers, no peripheral nerve thickening. This picture shows bilateral EDB hypertrophy along with the wasting of the medial plantar arch and hamartos. Coming to vitals examination, pulse is 82 per minute, regular, normal in volume and character. All peripheral pulses are palpable. Respiratory rate is 16 per minute, regular. BP in supine position is 110 per 76 millimeter of mercury in the right upper limb. In standing, it is 120 per 80 millimeter of mercury. Single breath count is 25. Height neck ratio is 11.7. Coming to higher mental functions, is attention, memory, language are normal. MMSE is 30 per 30 and lobar function assessment also normal. Coming to cranial nerve examination, all cranial nerves were normal, sir. Olfaction normal bilaterally. Cranial nerve 2, visual acuity, visual field, color vision, fundus normal bilaterally. 3, 4, 6, bilateral EOM full, no ptosis, nystagmus. Saccades and pursuit were normal. Optokinetic nystagmus, normal response. Direct and indirect light reflexes were present, normal bilateral. Fifth nerve, both sensory, motor were normal.
You go to spinomuscular motor system. When the cranial is normal, you can go ahead.
Yes, cranial nerves are normal. In trunk, there is no fibrillation. Spinomotor system examination. Bulk. There is a mild asymmetry in the bulk in the left upper limb, left arm, 1 centimeter less than the right arm, and in thigh, 2 centimeter right thigh is less than the left one, and the leg calf is 1 centimeter less on the left side, sir. And this picture shows bilateral dorsal interosseous, mild dorsal interosseous wasting, sir. And bilateral apparent calf enlargement was present, sir. And he has also bilateral postural tremors present, sir. Coming to tone, his upper limb tone was normal, lower limb hypotonia present bilaterally. Power examination, trapezius normal bilaterally, supraspinatus weak bilaterally, infraspinatus rhomboid spectralis, latissimus dorsi weak bilaterally, serratus anterior weak. Deltoid, in the right arm it is 4, MRC grade 4, and in the left arm it is MRC grade 3. Biceps 4 plus and 4 minus, triceps it is 4 minus and 3, brachioradialis it is 4 plus and 4. So in upper limb proximal, there is a asymmetricity between right and left, and also triceps is more weaker than biceps. Coming to distal upper limb, distal mild weakness, wrist flexion extension almost 4 plus. All the other small intrinsic muscles of hand like abductor pollicis brevis opponens, abductor digiti minimi, palmar interosseous, dorsal interosseous, and lumbricals were weak. Coming to lower limb power, iliopsoas power 3, gluteus maximus 4, gluteus medius and minimus 4 minus, adductors 3, quadriceps 3, and hamstrings 4 minus and 4. So the more weak muscles are hip flexion, adduction, and knee extension. Distal lower limb, ankle dorsiflexion is a bit weaker than plantar flexion, sir. 4, and plantar flexion is 4 plus. Inversion, eversion were weak. Toe flexion, extension, toe flexion was 4 plus and extension was 4. Extension is 4 bilaterally. So this video shows that he could not get up from his sitting position, sir. He uses his hip abductor to stabilize him. Neck flexion, grade 5, neck extension, grade 5, Deaver sign negative, no scapular winging, no percussion or grip myotonia, fatigability test, negative, sir. So though he denied any fasciculations on examination, we found he had fasciculations in the left biceps region, sir. Superficial reflexes were present, plantar flexor on bilaterally. Coming to deep tendon reflexes, jaw jerk not elicitable. All the reflexes were hyporeflexic, sir, from biceps, triceps, supinator, knee and ankle jerk. Universal hyporeflexia present, sir. Sensory system examination normal. Stance normal, gait, waddling gait present. Coordination normal bilaterally. Extrapyramidal system normal, sir. Autonomic nerve system normal. Spine and cranium normal. Other system examination normal. CVS, the apical impulse felt in the left to fifth intercostal space, half inch medial to the midclavicular line, sir. No hepatosplenomegaly in the abdomen. Summarizing after examination, a 22-year-old male, firstborn of third degree consanguinity with normal developmental milestones and cognition, presented with insidious onset, slowly progressive weakness of all four limbs. Initially started in the lower limb proximal, followed by distal, flail type of weakness, then bilateral upper limb proximal weakness. There is a asymmetricity in the upper limb, thinning of the shoulder girdle muscles, distal hand and foot muscles, asymmetrical thinning of calf, hyporeflexia, fasciculations in the left upper limb with postural tremors of both hands, waddling gait with normal sensory, cerebellum, extrapyramidal system and autonomic nerve system. So structure localization after examination, anterior horn cell would be my first possibility, sir. In anterior horn cell disease, I would like to consider spinal muscular atrophy, considering his age of onset and slowly progressive. It could be SMA type 3, sir, 3B. But still the CDB hypertrophy and calf hypertrophy, I would like to rule out muscle disease also.
Like what?
Muscle disease presenting with fasciculation is though rare, except for this metabolic myopathy like Pompe's and hypothyroid. Or
What about the postural tremor?
postural tremor, it is neurogenic type of tremor, sir. It looks like mini polymyoclonus, sir.
Can it occur with myopathies?
Very rare, sir. It cannot occur.
Cannot, don't say cannot in any condition. See, we just do not know. There's nothing like cannot or no in neurology or medicine. There is always a possibility. Yes, it can happen. In certain distal myopathies, postural tremors can happen.
Okay, sir.
And particularly with significant wasting, you can have. So don't say no. It's possible, though it's low down on the list.
Yes.
So in myopathies can produce tremors. It's not that it cannot.
Okay, sir.
Continue.
Shall I proceed with investigation, sir?
Depends on Shivkumar and Aliasan.
Aliasan, sir, shall we proceed with the investigation?
Can you ask anybody whether anybody wants to offer anything? Why don't you open it?
Is there any possibility of hereditary neuropathy? Can areflexia?
Hyporeflexia.
Hyperreflexia. There's a possibility of it, but fine, it may be lower in the life. But you have to consider the possibility because starting from the 5 years of age. The 2 points.
Divya, does this uniform hyporeflexia go in favor of a muscle disease or an anterior muscle disease?
Sir, presence of angle jerk favors muscle disease, sir, but in anterior muscle there can be universal hyporeflexia or areflexia, sir.
No, see, you said all the reflexes were hyporeflexic. Does it go with a muscle disease or an anterior muscle disease? Specific question.
Anterior horn cell is first.
Sorry?
Anterior horn cell is my first DD, sir. Muscle could also be possible, sir.
Can I ask you why?
Sir,
See, the reflexes, if the reflexes become hypo or areflexic, it points out to, in a muscle disease, it points out to weakness of the muscles.
Yes, sir.
Unless the weakness of the muscle is significant, or pari passu with the loss of reflexes, generally, it does not reflect a muscle disease.
Yes, sir.
But with an anterior hornsel disease, you can have a uniform hyporeflexia, particularly in SMA. This was a clinical point of discussion, probably still useful. But of course, now with the genetic findings, these findings could change. Okay, go ahead as per what, there must be other people who can comment on this.
Sir, Dr.
Yeah,
Megan,
Yes, Eugene.
yes, Megan, sir, of course, go ahead.
is there any evidence of neck muscle weakness? You said the neck muscles are not weak,
Yes,
but from the history till the presentation,
yes, sir.
you didn't say anything about the prominence of the neck muscles and the winging of the scapula. All those things may give us a clue whether it is
There is no neck muscle weakness, sir. No winging of scapula, sir.
abdominal muscles.
Abdominal muscles were weak, sir. Truncal weakness is present, sir.
So I think from the history also, you should say that you have not mentioned anything about that. And when the patient comes up, or what about the winging of the scapula, seen or not? You said Serect is weak.
Yes, sir. But there is no obvious winging of the scapula, sir.
What happens to that? It goes directly, or
Upper limb weakness is very minimal, sir. It is almost 4 plus power, sir.
did you look for it is a 4 plus power? Then it is. Did you try to see that?
Yes, sir.
Similarly, respiratory weakness or any other abdominal muscle weakness, or even the diaphragm you can look for, because those things may give us a clue, clinical clue, even before going into other, and the presence of cramps.
Yes, sir.
You don't have any slide, but how, when did you test, how did you test for that and look for winging?
Abdominal muscles, sir.
It's bilaterally symmetrical, asymmetrical serratus, because
Winging,
those things may give us, because we have to rule out Becker's in this. No?
yes, sir. Winging, I don't have a video, sir.
Thank you.
Vijayan.
Madam, sir, was an ECG done in this patient? ECG.
Yes, sir.
I was interested.
Shall I proceed?
And
with the investigation, sir?
Did
She
the
has not come to
ECG show?
investigations yet.
Okay. No, because she told about the hand tremor.
Shall I proceed, sir?
Please.
Sir, we would like to know the forum's final opinion, whether it is a nerve disease or muscle disease. That is the crux of the problem. Either we can conclude at this stage whether this is muscle disease or nerve disease.
Did she see fasciculation in any other area?
Yes, sir. He has fasciculations in the left upper limb. That is
There's only area, one part she showed.
pectoral muscles, pectoral and biceps.
Yes, sir. I could find in only one limb, sir.
No other area. And the patient is not aware of it.
Yes, sir. He's not aware of that.
Because, but for that, it looks more of muscle disease rather than anti-Hodgson. But if the fasciculations are there, very prominent, it is more in favor of anti-Hodgson.
Okay, sir.
Sivakumar. So at this, so even after the examination, it's very difficult to say whether it is a muscle or nerve.
Sir, I feel that asymmetry is in more favor of asymmetry in fasciculations, more in favor of spinal muscular atrophy. That is a nerve disease than muscle disease. Otherwise, I also have to wait for investigations.
The cramps also into consideration.
Cramps.
We've left off the cramps.
Yes, sir. Cramps indicate cramps and fasciculation both indicate motor neuron hyperexcitability, sir. So it could be present in muscle disease and also in nerve disease, sir. It is an element. It indicates element.
Right. So where are we?
But it is more in favor of a nerve disease than a muscle disease, and cramps, and that's what I thought at least.
In conjunction with EDB and calf muscle hypertrophy, Vijayan.
Yes, sir. That is the only thing that is. But any severe proximal muscle weakness is going to produce EDP hypertrophy. So that is only weakness is going to produce EDP hypertrophy. That's what is the basis of EDP hypertrophy in most of, because it gets paired and gets hypertrophy because of significant proximal weakness. So
not always true. It is usually attributed due to a muscle disease, isn't it?
yes, sir. It's usually attributed to muscle disease. The only thing is that is the only thing that is standing out. So I thought if we take away that, if the fasciculations, the cramps are taken into account, then as she told, more in favor of a nerve disease rather than a muscle disease.
Siva, I would go in for a muscle disease, Siva.
I will also opt for muscle disease.
It is very difficult.
My first impression is nerve disease, sir, because of these 2 points, the asymmetrical and as well as the fasciculations. Fasciculations are very prominent, sir, which is unlikely in a muscle disease.
But single muscle.
But so very prominent, sir, that is a muscle, the fasciculation is seen in a more weak muscle.
So neck
One muscle
muscle,
only, isn't it? It was only in one muscle.
so when neck muscles are not involved, the muscle disease is not very is commonly seen. Usually neck muscles are involved.
Sir, Justin, sir.
Yes, Justin.
Yes, yes.
Sir, is there any differential wasting, sir?
Yes, there is some differential wasting is there.
Mainly which group, sir? Cervical or lumbar, sir? Region, sir? Region-wise?
Sir, in the same L5 distribution, there was differential wasting, sir.
Which muscle is wasted? Which muscle is in which number? Which root correspond?
The L5 root, the EDB is third, whereas the extensor.
The muscle supplying by the L5 root, some muscles are wasted, some muscles are normal.
Yes, sir.
If it is so?
Yes, sir.
Milani, where are you?
Okay. Wasting
Sun
is more
Pharma,
than
please
weakness or
mute
weakness
everybody,
is more
sir.
than weakness?
Sir,
Wasting is more than weakness or weakness is more than wasting?
sir, weakness is more, sir.
Sir, mute everybody, sir. Mute everybody, please.
Weakness is you said 4 by 5.
Then,
Am I right?
sir, in lower limbs it is 3, sir, proximal.
Okay.
Distal 4 and 4 plus, sir. In upper limb, 4, sir, proximal, distal 4 plus.
That means the wasting is more than weakness.
Yes. Wasting also
You have thinned out muscles in the distal.
mild distal wasting was present, sir. Not very obvious wasting.
Because that gives a clue that whether it is an anteroconsal or not. Then your cramps again points to the anteroconsal. It's a non-motor manifestation of anteroconsal.
Yes, sir.
Again.
Okay, let's proceed. We'll see what it turns out to
Yes.
be. It's difficult.
Okay.
Maybe points for both. Let's go ahead.
Yes, sir.
Because time is running out.
Normal blood investigation, normal, peripheral smear study is normal, VCTC negative, RFT, LFT normal. RFT normal, sir. LFT, there was mild elevation in the ST, OT, and PT, sir. Apart from that, normal, sir. Thyroid profile normal. Serum CPK was 728, sir. We repeated it again. It was 704. ECG is normal sinus rhythm, sir. No abnormalities. Here, 2D echo is normal.
Sir, please mute everybody, sir. Sun Pharma people, please mute everybody.
We did a nerve conduction study, sir. Both motor and sensory nerve conduction studies were normal, sir. EMG showed spontaneous activity with the fibrillation potential present in the spontaneous activity, sir. In MUP, long duration, normal amplitude polyphasic waves with normal recruitment and complete interference pattern was seen, sir. Shall I proceed, sir?
Yeah, go ahead.
Can you show the fibrillation potential? You have
Yes.
recorded?
Just a minute, sir.
Because that's very important here. Because you show the complete interference pattern and more in favor of myopathy. And we had clinically fasciculation. You have to look for fibrillation, which is more important.
Yes, sir. Just a minute.
That's going to change the whole diagnosis.
Is it visible, sir? Zoom is not open. Zoom is not open.
It's okay, ma'am, but you found
Okay.
fasciculations. You found fibrillations, isn't it?
Sir?
You found fibrillations.
Yes, now I will share, sir. We found fibrillation.
We'll take it. Go ahead with the biopsy.
Biopsy.
Yeah, go ahead. We don't have much time.
Type 1 fiber grouping, sir.
Okay.
Genetic diagnosis. One gene deleted in the chromosome 5 involving exon 7.
You are not audible.
Now, sir.
If your voice is not audible, what is the biopsy report?
Can you hear me now, sir?
Yes.
Sir, biopsy report showed type 1 fiber grouping with neurogenic changes, sir.
Okay.
And we proceeded with genetic analysis, sir. It showed SMN1 gene deletion in the chromosome 5 involving exon 7 and 8, sir.
Good.
The muscle hypertrophy in type 3 SMA, the type has been highlighted through various studies, sir. The possible mechanism is continuous discharge of muscle fibers, sir. And the recent hypothesis is that the overexpression of mechanistic target of rapamycin leading to activation of protein synthesis, sir. Thank you, sir.
Thank you. Thank you.
So thank you, Divya, for your excellent presentation.
Thank you, sir.
But I think the atypical feature in this case is the tremor, isn't it?
Yes, sir.
And
Facet.
you have also mentioned about the postural tremor.
Yes, sir.
Sir, one doubt, is not so much of wasting, but areflexia and hyperreflexia. Who can explain? It may occur in SMA, but explanation is areflexia, hyperreflexia. Hello. Hello, sir.
Okay.
Yes, Tirur children,
any-
that is quite classical, isn't it?
Yes.
Where you have, where you do not have much of weakness and yet the reflexes are down. That's quite classical of an SMA. That is what we said. That goes in favor of an SMA. Not muscle, not much of muscle weakness.
So some part of muscle is there to produce a reflex.
Correct.
It's not full wasting.
Yes, sir.
Mostly maybe has to be present.
Yes, sir.
It's
That
very
point
interesting.
features,
It's a very interesting EMGs because it has got both fibrillation potential
Okay.
with complete interference pattern.
Okay.
And clinically and genetic shows genetic defect. It's very interesting because
maybe it would depend on which muscle was sampled, and that muscle might not have shown much of weakness.
Okay.
And that is why recruitment is normal, interference is normal.
And CPK is raised.
Okay.
That's marginal raise.
Anyhow, it is not decreased.
Less than 1,000. We do see that in neural diseases also.
Yeah.
That's what the differentiation is not that clear cut.
And
So
now
you necessarily have to go for muscle biopsy and gene testing.
That is the reason nowadays we don't go for muscle biopsy. We straight away go for genetic testing.
Agreed, sir.
Thank you.
Okay, thank you. We'll move to the next case.
Thank you, sir.
I request Bala Pradeep to present an interesting case of freezing gait.
Good morning, sir. I'm Dr. Bala Pradeep. I thank my HOD, Sir Dr. Shivakumar, Professor Thiruvalchelvan, sir, for giving me this opportunity. Today, I'm presenting a case of freezing gait for discussion. Mr. Devaraj, 64 years old, gentleman, studied up to 10th standard, working as oil extract machine repair worker, right-handed, coming from Europe, informant self and his son, and reliability is fair. Present with chief complaints of difficulty in walking for 6 months, slowness of activities of daily living for 6 months. History of present illness. Patient was apparently normal 6 months back when he noticed difficulty in walking, which was insidious onset, gradually progressive. Difficulty in the form of initiating steps with right foot, associated with tremulousness of right leg while standing and while walking. He has to wait for 5 to 10 minutes and then slowly make short steps. After 5 to 10 steps, he again finds difficulty to initiate next step, and this process repeats while walking, more with the right leg. History of difficulty in turning while walking, takes support of the wall or nearby objects and then turns in multiple small steps. History of tendency to fall while walking, but did not fall so far. So he started using stick to manage himself from falling. There is history of slowness of all activities of daily living since 6 months, like eating, brushing, bathing, washing face, wearing shirt, combing hair, etc. He often requires support of his family members. No history of tremulousness of upper limb or leg or hand. History of difficulty in insulating chapels since 6 months with slippage of chapels in foot with awareness while walking. History of mild difficulty with pain when getting up from floor, no difficulty when getting up from chair. History of mild difficulty with pain in raising both arms above head, no history of difficulty in bringing food to mouth, no history of difficulty in combing hair, no history of difficulty in mixing food, opening bottle cap, door handle, buttoning or unbuttoning a shirt. History of stiffness in the right lower limb present and back noted with history of difficulty to freely turn body side to side and difficulty in bending forward. No history of thinning or twitching of muscles. No history of difficulty in getting. History of low back pain, bilateral shoulder joint pain, and bilateral knee joint pain present for the past 2 years. And history of bladder disturbance present since 3 months in the form of increased frequency, urgency, and urgent incontinence more at the night. He was able to feel bladder and bowel sensation. No history of constipation, no history of abdominal sweating or coastal giddiness. History of sleep disturbances present in the form of decreased sleep, difficulty in initiating sleep with frequent awakenings in sleep, no history of snoring, shouting, or kicking behavior. No history of emotional ability, memory or behavioral disturbances, no history of speech disturbances, able to understand and reply appropriately and was able to read, write, and name things. No history of auditory visual hallucinations, no history of altered sensorium, seizures, involuntary movements, sudden jerks, able to use brush, dress correctly, able to make simple calculations and get change in market appropriately, able to tell time in wall clock, able to navigate to familiar landmarks, interacts well with family members, neighbors, and relatives. No history of perseveration of in daily activities. No history of any socially inappropriate behavior. There is difficulty in perceiving smell for past 2 years and able to see near and distant vision, differentiate colors, no night blindness, but there is difficulty in turning eyeballs in all directions. Turns head to see the objects. Other granules like able to feel sensation over face and chew food, able to close eyes and lips, rinse mouth, appreciate taste, able to hear normally, no history of giddiness, able to swallow both solids and liquid foods, able to turn head side to side, able to protrude tongue, marshal food inside the mouth, able to feel touch, cloth sensation, insect bite, hot and cold sensation, able to appreciate ground normally, no history of increased unsteadiness in dark or while washing face, no history of swaying while walking, no history of difficulty negotiating through narrow passages, no history of chest pain, palpitations, abdominal distension, no history of decreased appetite, weight loss, no history of fever, headache, or vomiting, no head trauma, no history of toxin exposure or drug exposure, vaccination, or radiation exposure. In the past history, he had a spinal surgery for the traumatic dorsal spine fracture in 2017. Post-operative was uneventful. Personal history is he takes mixed diet, non-smoker. He takes alcohol for 30 years, 180 ml per week. Family history, no similar illness in the family. Summary, 64 years old male with history of gait disturbances for past 6 months in the form of initiating difficulty, turning difficulty, gait freezing with stiffness and tremulousness of right leg, with tendency to fall and slowness of activities of daily living. And he also has history of hyposmia and increased frequency and urgency of micturition, sleep disturbances without involving cognitive, speech, bulbar, sensory, and cerebellar function.
Right. Localization.
Any history of diabetes or hypertension or hypercholesterolemia? Any risk factors for ischemia?
No, sir. No history of diabetes, sir. No history of hypertension or the risk factors of cardiovascular risk factors, sir.
Right.
History of falls.
Sir, there is tendency to fall, sir, but he did not fall so far, sir. He has fear of falling, so that's why he's using stick, walking stick, sir.
Okay. Start localization.
Sir, localization structures involved, sir. For his initial symptom like great freezing and initiation, I want to keep in left frontal lobe, sir, or extrapyramidal system. For his stiffness of right lower limb and postural instability and slowness of all daily activities, I want to keep in bilateral extrapyramidal system, sir, like basal ganglion connections. And bladder symptoms, I want to localize in frontal lobe itself or otherwise and autonomic nervous system.
Right, in the history, and you have mentioned that this patient has got difficulty in inserting the foot into slipper, and also he has got some difficulty in holding the slippers.
Yes, sir.
Would you want to place a lesion? Hello?
That can be front, that can explain frontal bilateral foot involvement, bilateral overlimb, distal predominant.
He has a difficulty in the insertion of foot into
Yes,
slipper
sir.
and difficulty in holding. Can it be due to pyramidal weakness?
Yes, sir, pyramidal weakness, sir. Or
Yes.
can be pyramidal weakness involving frontal or other extrapyramidal weakness also can be. Due to the tremulousness also he finds maybe weakness, maybe difficulty in infinity. Or due to rigidity also he may find gripping the.
Okay.
Is it due to gait apraxia? Gait apraxia is having a apraxia of the limb.
Yes,
Is it because of difficulty in initiating due to the gait
Yes,
apraxia?
sir. Yes, sir. Gait apraxia, sir.
No, how do you come to that conclusion? It's apraxia. See, we have not seen the great yet, but how did you come to the conclusion it is apraxia?
Sir, he's having a difficulty in initiating, sir. That is, in spite of he's able to walk, he has an initiation failure. There could be an apraxia.
Maybe apraxia, sir. Because he finding difficulty in initiating the foot in spite of normal.
Siva, if we say it is apraxia, are we not localizing it to the cortex? Do you think only the cortex is involved in freezing of gait? Or not the subcortical structures more often the cause of a freezing of gait?
Freezing is ill-localized. It's only frontal lobe we are
Exactly.
Yes,
So why do we, without seeing the video, why do we point to say it is an apraxia?
When he has got a freezing, sir, is it possible to say that the patient has got a pyramidal weakness or any weakness in that matter, sir?
Not pyramidal. Usually it can involve the cortex, but mostly subcortical structures, the basal ganglia, the brainstem structure, the cerebellum, all of these could cause a freezing of gait. I mean, as we know, it's all interaction of these pathways. So pyramidal per se need not come into play as far as freezing of gait, as far as I can think of.
It should be
anyway, the video should be more informative.
Should we say that there is a weakness also in addition to that, when there is a freezing, sir?
Depends on the examination finding.
Okay, sir.
Right, you can proceed with the examination.
Okay, sir.
Or you want to discuss differential possibilities with this history?
Possibilities, sir. Sir, first I want to keep a degenerative etiology, sir. First possibility, like atypical Parkinsonism or a non-motor hydrocephalus, sir. Second possibility may be vascular Parkinsonism.
Oh, 1 minute. Oh, why is it an atypical Parkinsonism?
Because in Parkinson, usually that bradykinesis will be there, sir, but that tremor and postural instability will be there, sir. But that lower body predominant with freezing types will be late in Parkinson's, idiopathic Parkinson.
So far, you have said it's only on one side. It started off with difficulty on the right side. It stays with difficulty on the right side. It's a unilateral presentation as so far what you have presented. So, and it started off in the lower limb, it's freezing of gait. Agree. The freezing of starting with freezing of gait is little unusual with Parkinson's. Yes. But that is something which could have brought him to notice. He could have had unnoticeable symptoms earlier or signs earlier. But this is what brought him to notice, brought him to you, because he has been having this difficulty of freezing, which means there is progression. So I agree, it can be atypical, but there is nothing to say it can't be, or it is only atypical, it's not Parkinson's. There are several features which go in with Parkinson's also, with hyposmia and features, unless, of course, we just say this is of a short duration, 6 months. That is what is a red flag.
Early bladder involvement.
And early bladder also.
That doesn't say it is atypical Parkinson's.
Atypical Parkinsonism is a misleading terminology.
Okay, go ahead, Bala.
Sir, vascular Parkinsonism, because the lower body predominant, sir. started with lower limbs only. Otherwise,
Let's
any
go on.
trauma-
Let's go on to the findings and let's see video.
Okay, sir. Sir, general examination, hypomemic face, edentless teeth, reduced blink rate 6 to 8 per minute, surgical scar at the level of thoracic vertebra, bilateral varicose veins, bilateral pedal limb present, bilateral knee joint tenderness swelling, no neurocutaneous markers, spinal deformity, and vitals pulse 78 per minute, normal rhythm, volume character felt in all peripheral pulses, blood pressure 140 by 90 millimeters mercury, right arm supine, and after 3 minutes 146 by 100 in standing position, no postal hypotension, respiratory is 18 per minute, regular, temperature normal, height 160 centimeters, weight 65 kgs, height neck wrist 12. Higher mental functions, sir. Conscious, oriented to time, place, person, cooperative. MMSC score is 27 by 30. Language is normal, sir. Spontaneous speech, fluency, prosody, grammar, syntax is also normal. No initiation difficulty, no paraphrases, circumlocutions, or word finding difficulty. Comprehension, repetition, naming, reading, and writing normal. Frontal lobe test, sir. Level of consciousness is alert. Orientation to time, place, person present. Tapir test is commission 3 and omission 2, sir. Attention deficit is there. Working memory, digit backward is 2, sir. Response inhibition, no error, sir. Mental flexibility, there is error, sir. Fluency test, fastest is able to tell 5 words, sir. It is less than 9, so it is little bit reduced the fluency also. Test of sequencing, graphic sequencing, and manual sequencing is able to do, but with 3 consecutive alone, sir. 2, so it is also reduced, sir. And abstract thinking, probe interpretation, he is able to tell only the concrete meaning. Similarly, dissimilarities he can't able to tell, sir. So the frontal lobe, mainly that dorsolateral prefrontal cortex, that mental flexibility and this executive function is affected. Temporal lobe, immediate memory, normal, sir. Recent memory intact, sir. Remote memory intact. Working memory, this is backward test 2 only. Episodic and semantic memory intact. Left parietal lobe, ideation apraxia, ideomotor apraxia, limb kinetic apraxia is normal, sir. He is able to do all the tasks with sequence, sir. Left parietal lobe, calculation normal, sir. Finger nose is normal, no right to left disorientation. Right parietal lobe, hemineglect, sir. He is able to bisect the line horizontal in the center. And clock drawing, he is able to do fair enough, sir. Constructional apraxia, intersecting pentagons, he is able to do, sir. No dressing apraxia and topography disorientation is absent, sir. Occipital lobe is normal, sir. Examination of cranial nerves. Cranial nerve 1, smell not perceived in both nostrils. Second cranial nerve, vision 6 by 12 bilaterally. Otherwise, fundus normal, sir. 3, 4, 6 cranial nerves, no ptosis, no diplopia, no nystagmus. Pupils reacting to light bilaterally. And upgrade restricted, upgrade impairment is present in bilateral eyes. 5th cranial nerve, sensation over V1, V2, V3 intact. Motor is normal, sir. Corneal conjunctival reflex present. Jaw jerk is brisk, sir. 7th cranial nerve, no facial weakness or asymmetry. 8th normal, sir. 9th, 10th, uvula midline. Palatal movements normal on both sides. 11th cranial nerve able to shrug shoulders against distance and turn head side to side again. And 12th is also normal, sir. So this is a video of upgrades by this, sir. So spinal motor system bulk symmetrical, no apparent wasting. Tone, right side upper and lower limb increase, sir. Left side lower limb increase, sir. Power, upper limb normal, sir. Lower limb hip flexion, abduction, extension, adduction 4 plus, sir, bilaterally. Knee flexion, extension 4 plus bilaterally. Ankle dorsiflexion, plantar flexion is 4, sir, bilateral. Reflexes, superficial reflex, abdominal and cremaster reflex on left side absent, sir, right side present. Plantar is left side extensor, sir. Right side flexor. DTR, trapezius reflex brisk, sir. And the rest reflex biceps, triceps, supinator. Brisk on the 3 plus on the left side, sir. Right side 2 plus. Knees at bilateral 3 plus. Ankle 2 plus, sir, bilateral. Pathological reflexes like Hoffman's and Wartenberg's present on left side, sir. Primitive reflexes, snout present, palmomental present, sir. Globular tap is positive. This is a gate freezing, sir. Sir, can I proceed?
Yes.
The gait stands, sir. Stoop posture starts with hesitation, short shuffling steps. Gait is freezing type. Extrapyramidal system, hypomemic facies, bradykinesia, grade 2 in right upper limb and grade 1 left upper limb. Rigidity is present in neck also, sir. Right upper limb, grade 1, left upper limb, no rigidity, sir. Bilateral lower limb, grade 3. No rest tremor, action tremor, postal tremor, sir. Micrography is present. Full test is tendency to fall if not caught. Sensory system is normal, sir. Rombox negative. Cortical sensation is normal. No cerebral signs, no meningeal signs. Spine and cranium normal. Other systems are also normal. The summary: 64 years old male with chronic neurological illness in 6 months. Incidence also gradually progressive with history of gait initiating difficulty, turning difficulty, gait freezing, right more than left with rigidity, bradykinesia, paraparesis, distal more than proximal, exaggerated reflexes, brisk jogger, plantar extensor with frontal lobe involving planning and executive dysfunction, hypoosmia, upgaze restriction, bladder disturbance in the form of frequency and urgency, and sleep disturbances, without involving speech, bulbar, sensory, and cerebellar function.
Okay. So what are all the possibilities?
Before that, what is his BP in lying posture, in sitting posture, BP? Any change?
There is no change, sir. BP 140/90, sir, in right upper limb, supine position, sir. And after 3 minutes of standing, 146/100, sir.
Were you able to notice any dystonia?
No, sir.
Upper limbs on stretching out?
No, sir.
And there's no droop of the shoulder either?
No, sir.
This patient has cervical rigidity, but you have mentioned tone is increased in the upper and lower limbs. What type of hypotonia? Is spasticity or rigidity?
Rigidity,
in the limbs.
Rigidity, sir.
Right. So what about others? Any possible?
He seems to have involvement of the extrapyramidal and the pyramidal system. Possibly one of those pallidopyramidal syndromes wherein genetic abnormalities are well documented. It could come under NBIA also, neuronal brain iron accumulation, or what is coming to notice of late is this PLA2G6 mutation, which we seem to be seeing nowadays more often because we are doing the genetic study. I think these are the two things which come to my mind.
I want to.
Okay. Proceed with the investigations.
This involve left frontal lobe, terminal tract above pons surface because the disc is Jadark, and bilateral extrapyramidal system, sir. Proceed for investigation, sir.
Yes.
Okay. The investigations, routine CBC, blood sugar, RFT, LFT, thyroid normal, sir. HIV not reactive, VDL negative, sir. So this is the MRI of the patient, sir. E2 image showing hyperintensity in the subcortical around the coronary radius,
sir. Any comments about the linear hyperintensity seen here on the pallidum? The one below that, the one below, and the arrow showing the below one, the lower one. That's it. On the right side, you see a linear abnormality there.
Okay.
That's it. That's it. Does it suggest anything? That's been described as a feature of this PCAN, MCAN, that is brain iron accumulation disorders. Anyway, you proceed. I am biased.
This is explain restrictions. So this is as still view, sir.
T1 axial you have. T1 axial.
Not this.
Sorry.
It is not this, not available.
Okay. Show the T2 axial once again. Yeah. See, that's striking there. Okay. That right side, that linear hyperintensity is something which is okay. Go ahead. Standing out. Genetic studies.
Not
Siva.
Sir, only clinical and image wise, sir, the discussion. There is no studies done for this patient, sir.
I see. Would you agree this is a pallidopyramidal syndrome?
Not aware of this, sir.
No, he has involvement of the basal ganglia. He has
It
involvement
is
of
a
the
vascular problem.
He has significant white matter hyperintensities agreed to, but there are no vascular risk factors. And see, we very often see these pictures with neurodegenerative disorders also. That is if you want to call them as leukoariosis, it is anyway. All suggest subcortical involvement. But the clinical picture is, see, you don't get this sort of a picture in vascular disorders. And this one is striking, this abnormality on T2. You see that linear hyperintensity in the basal ganglia, in the palatal region. It's very striking. That's been a feature of this PCAN and brain iron accumulation disorders. And if you do that study GLA to P6, I think that one genetic study might be helpful, because nowadays it's being described more often. It's been described from my institute also.
Okay. Here only 6 months is there.
That's all the more interesting. That's all the more interesting. That's why either it was subclinical earlier and it has come to his notice because of the gait difficulty, or if it is 6 months, then we'll have to think, you will have to consider also, if it is a short duration, you will have to consider autoimmune also. But there's autoimmune, nothing fits into this clinical picture. This is a predominant unilateral presentation to start with, and then of course both sides. I think NBIA is
was there a dystonia, sir? Prominent dystonia?
That's what I asked Vijayan. I asked that. He said no.
No, sir, no dystonia.
If it was there, it classically fits in.
Classically fits in with pallidopyramidal syndrome. Otherwise, without
but still,
the dystonia,
I wouldn't exclude it.
What is the conclusion, sir? Finally,
that's what he has asked. Sivakumar wants our opinion on that.
This patient has responded well to L-DOPA, sir.
Okay.
They improved a lot with L-DOPA. Whether that has anything to do with this?
In that sense, it will go more in favor of a fairly characteristic Parkinson disease.
The Parkinson plus a stroke coexisting.
It's possible, yes. Some of these vascular Parkinsonisms do respond to syndopa, agreed. But so also this atypical Parkinsonism also 30% respond.
But there has to be a consistent improvement also, not only an improvement.
Correct. I think this is a patient wherein it would be better to do a genetic study, just one genetic study for neuronal brain iron accumulation.
We'll try to do
that also. And the other thing is also to do a high resolution SWI imaging. susceptibility weighted imaging, that also will show up neuronal brain ion accumulation.
Siva, and the second as well as the third picture on the lower frame, you see that distinct linear imaging there in the on the right side. That is something.
Yes,
Yeah,
Yes, sir.
that is what suggests NDIA.
Sir, why not high resolution susceptibility weighted imaging, sir?
Yeah, it might. Yes, certainly. Yes.
That will help in identifying.
Yeah, I do not. Do they have it in Mount Kumaramangalam?
Sir, it can be done, sir.
It should be possible. Yes, can discuss with the radiologist and find out.
We'll get it done when the patient comes back again, sir.
Okay. Thank you for that interesting presentation. But it looks like a pallidopyramid.
No,
Whatever
you,
be the etiology. The underlying cause, yes, it may be degenerative, it might be vascular, it may be, if you consider iron accumulation as a metabolic, it might be any of these. Thank you for a nice case.
Thank you, doctor. We'll move on to the next case. I call Dr. Krishna Priya to present an interesting case of a recurrent CNS disorder.
SW. Good morning, sir. Thank you for giving me this opportunity for presenting in this forum. My case is a case of a multifocal recurrent CNS lesion. So my patient name is Palanisamy, 51-year-old male patient. He studied up to 12th standard and is a right-handed individual and is born out of non-consanguineous marriage and is an office worker. The main presenting complaint of patient is a weakness of bilateral overlap for 1.5 month duration. Blood disturbance in the form of urgency for 1 month duration. So the history of presenting illness was the patient was apparently when in his usual state of health. He could walk around without assistance and do his daily activities. So 1.5 months back, he found difficulty in walking because of weakness of bilateral overlap. He could walk a certain distance, after which his legs would buckle and he had assistance to walk. This weakness is more on right lower limb when compared to left. And he also reported that he has difficulty in intimating food to chapels and difficulty in holding chapels. Also, patient has been finding it difficult to get up from the squatting position. The weakness progress over days, and patient has difficulty in standing and needs assistance while standing also. And he also had some difficulty in sitting up from lying down position. And over a duration of 1 month, patient was confined to bed. There is no history of difficulty in holding his neck in upright position. There is no history of difficulty in gripping objects with upper limb or doing overhead activities like comping. There is no history of fasciculation and no history of stiffness of limb. Over more than 1 month, the patient is having some increased frequency, increased urinary frequency and urgency. And he is not telling a history of any retention, incontinence, or he is able to feel the bladder fullness. And there is no history of numbness over limbs, and he is able to feel hot and cold water. No history of headache, seizure, vomiting, abnormal behavior, slurring of speech, fever, weight loss, and back pain. And he is able to appreciate smell, able to see near and distant objects clearly, and he is able to appreciate colors. And he is able to look into all directions, and he is able to feel sensation over face, few hard foods, able to drink through straw, whistle, blow, balloons, candle, and able to hear well, no tinnitus or giddiness. Now coming to past history, this patient past history is very significant. His complaint started in May 2003, and he had history of fever for 7 days, followed by weakness of the upper limb and lower limb with slurring of speech. And for this, he was consulted in some hospital, and they started him on ATT. And treatment continued for nearly 1.5 years. ATT continued for 1.5 years. And according to history, weakness and the slurring of speech improved after a course of 2 to 3 weeks. Again, in September 2003, he again readmitted with history of weakness of same left upper limb and lower limb, with decreased vision of left eye. And history is telling he improved after duration of treatment. He was admitted in hospital and treatment improved after duration of 3 weeks. Again in 2005, he was admitted with complaints of diplopia and loss of taste sensation with angle of mouth deviation to left. And also he's telling his symptoms improved after some time. Nearly through 3 weeks, 4 weeks, his symptoms improved. In 2002 February, after that he was normal, he was not on any treatment. And again in 2002 February, he had episode of seizures and he was admitted and again started on ATT after evaluation. And now patient is a diabetes non-case on, they started on OHA. And no significant person except he consumes alcohol once or twice in it. Coming to summary. 50-year-old male patient with history of recurrent neurological illness in the past, presented as hemiparesis, diplopia, decreased vision, weakness of right side of the face at varying intervals, now presented with subacute onset progressive flaccid asymmetrical weakness of bilateral lower limbs, with right lower limb more involved than the left, along with the bladder disturbance in the form of urinary urgency, with no upper limb involvement, with no associated sensory symptoms, no cranial nerve involvement, and no cerebellar involvement. Sir, can I proceed with the structure?
Yes.
Sir, according to present history, the structures, patient has symmetrical weakness of bilateral lower limb. With history, is telling some flaccid weakness in the, like buckling is telling in the history. So according to anatomical localization, can be Cauda corner syndrome is first possibility. But considering the past diagnosis, I have also thinking about the spinal cord lesion with the upper extent maybe above L1 with extensive lesion.
Can you think of a cortical lesion for this present weakness? Lower limb weakness with the bladder disturbances.
The patient is telling some flaccid weakness, sir. That is only possibility against the cortical weakness. He is telling some buckling, cortical weakness also one can possibility, but the buckling is and asymmetry is also there, sir. Patient is telling left side lower limb is more involved than the right lower limb. 2 points against cortical lesion.
Okay.
Presenter, what is your name? Bala, is it?
Sir, my name Krishna
Priya.
Krishna Priya. Krishna Priya, why don't you take the entire picture? Why are you talking only about the present problems, present presentation?
Yes,
yeah, you will have to take entirety.
Yes, sir.
And you already said it's a recurrent problem, recurrent neurologic deficit.
Yes, sir.
So put everything together and come out with a possibility.
Yes, sir. This or structures involved according to present lesion is maybe corner or spinal cord above L1 with extensive lesion. And considering the etiology, considering the past diagnosis, there is history of involvement of cortical, subcortical brainstem involvement with the spinal cord involvement with a decreased vision, optic neuritis may possibility. So my etiological diagnosis is like a possibility. First is multiple sclerosis, neuromyelitis optica pattern disorders, anti-MOG antibodies. And rare possibility also I am considering like CNS vasculitis, as there is no other systemic features before no present history, and sarcoidosis, sir.
No, Madam, I think sir was asking whether you want to include the different levels of neuroaxis. That was what sir was asking.
Exactly. You are on the point, Vijay.
Yes, sir. Maybe.
It's a multi-axial involvement, isn't it?
Yes, sir. Yes, sir.
So what are the structures which are affected?
Sir, one possibility, first I'm telling sir, 4 possibilities, sir, because there is urinary urgency, sir, and weakness of bilateral lower limbs, sir, with asymmetrical involvement of right more than left, sir. First possibility I am telling is code involvement, sir, in this at this present case. Considering the past history, we can make localized to brainstem, cortical, subcortical, and one history of optic neuritis is loss of vision can be.
What is there to say cortical?
Sir,
why do you say cortical?
First history is like weakness of left upper limb and lower limb slurring of speech, sir.
Yeah, that doesn't mean it's cortical.
Sir, it can localize to 3, maybe can be cortical, subcortical, or brainstem. It can be, sir.
So why go to cortical?
The first history, there is weakness of left upper limb and lower limb slurring of speech. That
yes, that could be a subcortical involvement.
Yes, sir.
Then again, there is a recurrence in the same side. Of course, this time with the optic nerve involvement.
Yes, sir. Third time with optic nerve involvement.
Possible optic nerve.
Yes, sir.
Then the third time is diplopia with taste sensation, which would probably suggest a brainstem involvement.
Yes, sir. Fontaine involvement can be that.
And now the possibility could either be a spinal cord or the brainstem.
Yes, sir.
Okay. Did you mention anywhere along the line that she had seizures?
Actually, not a present history, sir. One episode of past history is telling seizures, sir. In 2002 February, he is telling some episode of seizures, sir. In past history, sir.
Yeah, that's right. But
Yes,
everything, so much of the presentation is past only, no?
Yes, sir.
So if there had been a history of seizures, then probably you could bring in cortical also. But we
Yes,
need
sir.
to know what exactly was the seizure, the description of the seizure pattern
Yes, sir.
before we conclude on that. Okay, so it's a multi-axial involvement.
Yes,
It's
sir.
not only a cord involvement.
Yes, sir.
Okay. And now you can say what are the possible etiologies of this multi-axial involvement, which was all, which came and improved,
Yes,
except
sir.
the present one.
Yes, sir.
Okay.
So possible etiologies, sir.
Yeah, you already discussed those. You already mentioned. Fine. I
Yes,
think
sir.
there's no, if there is anything anybody else wants to add, they can go ahead. Allegations, sir, you can take over.
Yes, sir. Still with the examination findings, sir, will go.
Sir, I have doubts, sir. There is a gap of about 17 years. After the 2005, there is no patient was normal. So far, he has not developed anything. Whether we have to club it with the previous episodes or we have to take it as a separate one. This is a new illness.
Not unknown with MS. You're seeing patients who have been asymptomatic for up to 20 years even.
But okay, sir, we can think of it. But whether at this, because he is also now getting aged, whether the present symptom is a different illness than the previous one.
You can always consider that. But we will have to exclude the first possibility is very likely a demyelinating. Particularly, the features are very much suggestive of a demyelinating illness.
Okay, sir.
Always we can consider two possibilities. Why not? Let us see what the findings show.
Sir, examination, general examination is normal. Patient is conscious oriented, febrile, no pallor, no stress, no cyanosis clubbing, no lymphadenopathy. BP is 120/80 millimeter of mercury, pulse rate normal. And other specific examination, nutrition status normal. There is no neurocutaneous markers. Peripheral nerve thickening, there is no peripheral nerve thickening. No knuckle hyperpigmentation, bone, hair, nails normal. And higher mental status examination also normal. And cranial nerve examination is normal, sir. All cranial nerves are normal. All factoptic, everything is normal at present. Coming to motor system examination, bulk of muscles, the bilateral equal and symmetrical on all four limbs, arm, forearm, thigh and calf, it is equal and symmetrical. Tone is normal in all four limbs, bilateral upper limb, lower limb, flexor, extensor, everything is normal. And coming to power, upper limb power is normal. Shoulder joint, elbow joint, wrist joint, hand grip, everything is 5/5 power. Coming to lower limb power, right hip joint flexion extension is 1 and left is 4 power, sir. And right abduction is 0 power and left is 4 and adduction is 3. Right adduction is 0 power. And knee joint flexion extension, right is 1 and left is 4. And movement at angle joint is 0 power, sir. No, there is no movement of angle joint and there is no toe movements also. In case of left upper lower limit is 4/4 power, sir. Both angle joint and toe movement is 4 power. Coming to reflexes, superficial reflexes, corneal, conjunctival, palatal, gag reflex present, abdominal reflex absent, cremasteric absent, plantar, bilateral extensor. In case of deep reflexes, the biceps supinator is just diminished, triceps, knee, angle all absent, and jaw jerk is not elicited. And sensory system examination, right it is normal side, touch pain, temperature, joint position, vibration, right side it is normal. Left is telling some decreased sensation below D8 spinal cord level. And stance and gait could not assess, and there is no signs of cerebellar dysfunction. There is no signs of autonomic dysfunction, and there is no signs of meningeal irritation. And other systems, examination normal, respiratory system, gastrointestinal system, CV is normal. Coming to the summary after examination, sir. 50-year-old male patient with a history of recurrent neurological illness in the past, presented as hemiparesis, diplopia, decreased vision, and weakness of right side of face, varying intervals. Now presented with subacute onset, progressive, flaccid, asymmetrical weakness of bilateral lower limb, right more than left, along with bladder disturbance, the form of urinary urgency with no upper limb involvement, with no associated sensory symptoms, no cranial nerve involvement, and no cerebellar involvement. On examination, tone normal in all cranial nerves, higher mental function normal, with tone normal in all four limbs, with power on right lower limb reduced when compared to left, with absent triceps, knee jerk, angle jerk, and absent superficial reflexes like abdominal reflex, cremasteric reflex with bilateral plantar extensor, with spinothalamic tract sensation involved below right side on below D8 spinal level. So the structures involved, sir.
Yes.
Sir.
Yes.
The structures involved according to this examination is bilateral corticospinal tract and right spinothalamic tract at spinal cord level above D8 and below C6. As there is absent triceps.
Proceed. Proceed.
Proceed.
So my differential diagnosis after examination and history, sir. First possibility is again multiple sclerosis, neuromulti spectrum optica disorders, and antibody disorders, and rare possibilities like still I'm considering CNS vasculitis, sarcoidosis, other connective tissue disorders.
Okay, the previous presentations could fit in with any of these which you have mentioned there. Okay, possibly. What about the present presentation? Which of these would fit in with the, which of these differentials which you have mentioned would fit in with the present features, clinical features?
Sir, involvement of forward involvement is there, sir. More in favor of multiple sclerosis, sir.
Why?
Or NMSOD also possibility, sir. Both can be considered, sir.
Why not MOG?
Myelitis is the involvement of myelitis can be seen in.
No, why not MOG?
Yes, sir. MOG also possibility, sir. These three are possibilities, sir, after examination.
Go back to the previous slide of yours. Yeah. So with this, the question now asked is which of these is likely with this sort of a presentation which you have presented? In other words, what is this presentation characteristic of?
Sir, in this there is only involvement of myelitis.
Is the okay? I'll ask leading questions. Is the patient ambulant?
Sir, not bedridden, sir.
Why bedridden? Why should he be bedridden with grade 4 power in the left limb?
Sir, actually, truncal muscle weakness also he is telling, sir. Truncal muscle weakness.
Not he is telling. What are you seeing?
Examining also truncal muscle weakness is present, sir.
Okay, let it be there. But your power examination is grade 4.
So power examination, one limb is weak, sir. One limb is weak.
Right is one, sir. And
exactly.
Right is one on zero.
Exactly. One limb is weak. So what is this presentation? See, it's a fairly.
Sir,
I'm not saying it is.
Not long.
No, I'm not saying it is. Wait a minute. I'm not saying it is, but it is. It indicates a Brown-Sequard-like syndrome.
Yes, sir.
See, it's a Brown-Sequard-like syndrome with lateral-posterior column involvement on the right side.
Yes,
with
sir.
Possibly the only finding for a cortical. There is some weakness and there is an extensor plantar on the left.
Yes, sir.
So possibly yes. But it's an asymmetric presentation. The cord involvement is asymmetric.
Yes, sir.
And resembling a Brown-Sequard.
Yes, sir.
So if you consider that, then which of the above differential diagnosis would you think of? First possibility.
Sir, multiple sclerosis.
Yes, it's not a transverse myelitis picture.
Yes, sir.
For either an NMO, I'm talking of classical presentations.
Yes, sir.
So to consider an NMOSD or an anti-MOG. So certainly that goes in favor of MS.
Yes, sir.
It also goes in favor of a sarcoid. Sarcoid also you can get unilateral presentations like that.
Yes, sir.
Now that you will have to marry with the previous pictures and as Shivakumar pointed out, 17 years duration, which of these, and it was sort of first 3 years or 4 years, he had recurrent neurological involvement, isn't it? From 2002 to 2005.
Yes, sir, 2003.
So it was not that 17 years, and thereafter there has been a gap without any neurological illness.
Yes, sir.
So putting everything together, now what would be your first possibility, second and third?
The first possibility, multiple sclerosis, sir.
Yeah.
Second possibility, again.
Choice is yours. Are there any features to suggest a CNS vasculitis?
Sir, actually, no other systemic features present.
Exactly.
Sir.
That's important. That's important.
Sarcoidosis also no other systemic features present.
Okay.
Connective tissue disorders also.
But you will still keep them.
Yes, sir. Still.
Okay. Any other discussant, and then you can go ahead. If there is anybody else to discuss, let them discuss. Any other thoughts, allegations, sir?
Only the absent reflexes, sir. The triceps.
Yeah, that's another thing. Upper limb, particularly the upper limb triceps is down. The knee jerks. What is your explanation for that?
Sir, maybe prolongation of spinal shock may be possibility, sir. One possibility. Some
He
because
is not in a spinal shock at all. What do you say he's in a spinal shock?
or extensive involvement with the
See,
cord
you
edema
should not commit yourself unnecessarily. Where is the spinal shock involved here?
Oh, yes, sir.
As you yourself said, as Siva pointed out, it's a unilateral involvement.
Yes,
Why
sir.
do you bring in spinal shock to explain the absent reflexes bilateral and that too in the upper limb also?
Sir, no, multiple level involvement can be possibility, sir.
What multiple level involvement?
Means longitudinally large or edema can also we can explain with.
No. Involving what structure? That's what Vijayan wants to know. Why are the reflexes down?
Root involvement can be there, sir.
So what does it become now? We do not know when these reflex changes happened, whether it was due to the present episode or the previous episode. So both are possible.
Yes, sir.
So the root involvement suggests what?
Involvement.
What term will you give that? These are the questions you will be asked in the exam.
Edema.
Is it all due to myelitis?
Myelitis.
Sorry? I'm giving you a clue. Is it all myelitis?
Radiculitis and myelitis.
Yeah. So what do you call them?
Myeloradiculopathy.
Myeloradiculopathy, which may be the present one or some may be the past one. So
Yes.
if you, again, going back now, if you think this is a myeloradiculopathy,
Yes, sir.
then what would be your differential diagnosis? Which one comes first? Vijayan, you can continue, Vijayan. You can ask them. Ask her.
Sir, infectious cause can be myeloradiculopathy.
No, amongst
Listen,
the...
Among the demyelination.
Or vasculitis or sarcoid.
Vasculitis can be myeloradiculopathy.
Madam, sir wants to know which will you keep first now, NMOSD
No,
or
Vijayan,
MS? That's
Vijayan
what
wants
sir
to
is
know.
asking.
He only started it. Vijayan wants to know. Go ahead.
Sir wants to know which you will keep as the first differential diagnosis. That's all. Considering is a
Myeloradiculopathy.
prominent element.
Yes,
Yeah.
yes.
Root
That's
involvement.
what sir wants to know now.
Then any other study. So, CNS.
Okay, I'll give a clue. If it is my MS, how will you explain the absent reflexes? If it is NMOSD, how will you explain? That's all. Simple.
Sir, MS it can be root involvement, sir.
Yeah. Demyelination in the root entry zone. That's what you have to say.
Yes, sir.
But with prominent element features, then probably you'll keep NMOSD as the first differential diagnosis and MS as the second. Maybe.
Okay, sir. Yes, sir.
Okay, proceed.
Sir, with the investigations.
For investigation, routine blood investigation, hemoglobin normal, sir. Blood count normal, sir. And CSF analysis shows CSF cell count 14 cells with CSF protein elevated, sir, 114. And CSF glucose also normal, sir. This is the MRI spine finding, sir. It shows abnormal high signal intensity lesion with the cord starting from C6 to C6, C7, extending up to D11, sir. These are other images. Extensive spinal cord lesion starting from C6, sir.
Axial section.
The axial section is D10, D11 is available, sir. Here it shows.
No, is it a whole cord involvement or is it confined to one side?
Sir, actually it shows patchy involvement, sir. This section, D10, D11.
MRI brain is not taken.
MRI brain shows, sir, diffuse cortical atrophy, sir, with the bilateral periventricular hyperintensity. And post contrast MRI also no abnormal enhancing foci.
Here also you see white matter involvement. Okay. Whatever that means. Periventricular hyperintensity, what it means. What about VEPs?
Sir, VEP normal, sir. This time we done it was normal, sir.
Both sides.
Yes, sir.
She asked the previous MRI's reports, films are available. Whether we can show that, sir?
Yes, sir, of course. It's your presentation. Yes, go ahead.
These are the reports available, sir. The old reports In 2003, MRI brain they reported as normal, and September 2003 reporting as periventricular white matter discrete lesion, which are multiple in deep white matter, suggestive of demyelinating plaque. And August 2005, MRI brain showed multiple subcortical hyperintensity T2 lesions and on right cerebellar peduncle. And February 2022, T2 and flare hyperintensities in the medial temporal lobe on the left side, more of in favor of encephalitis. These are the old MRI.
1 minute over there. You said he had a loss of vision in the left eye.
Yes, sir.
And the VP is normal.
Yes, sir. Yes, sir.
So what do you think? How do you
Sir,
explain
that is a 2003, sir.
2003.
That is a 2003, but he lost vision in 2005.
VP was 2003, is it?
VP was 2003.
2003, sir.
So it was
And
not
vision lost
repeated
in
after,
2005.
it was not repeated in 2005.
VP was not done that time.
Is not, that report is not available in that record.
Okay.
So after considering all the final diagnosis can be multiple sclerosis, first possibility, and neuromyelitis optica, spectrum disorders, or anti-MOG antibody as a second.
And in the previous MRIs, the spinal cord was not included.
So no, sir. They the reports are collected from the old records, sir. They have given this reports. No MRI. I couldn't find any MRI spine imaging, sir.
Krishnapriya, you can go through what the treatment patient has received earlier from 2003 onwards.
Sir, they have given steroids, sir. In records, I got only steroids, sir. He have received on record May 2003 also I seen steroids only received, sir, with ATT in 2003. And February 2022 also he received ATT apart from steroids, sir.
His blood sugar was some 340 or something like that. When was it? Or he was he was a diabetic since when?
Yes, sir. RBS was. Hello, sir. Sir, actually, patient diagnosed with a diabetes recently, sir. And after the sugar, we started on insulin, sir.
On steroids.
Was an ANA done, doctor? Have you done an ANA profile?
No, sir, not done, sir.
Welcome, Professor UMS.
Sir, good morning, sir.
Morning. You were not there for a previous case discussion. You would have loved your opinion.
Sir, I
Which Shivakumar had presented.
I was in Tiruvannamalai temple, sir. Just got out of the temple. So I'm in the car.
Actually, I want to proceed with some other investigations also, sir.
Please, go ahead.
Actually, during MRI spine, they could identify, sir, one renal mass that this patient is having. And we have done the CCT abdomen showing right RCC of right kidney, sir. And these are the imaging findings of that, sir. This is a spine MRI we have taken. They found out some lesion in the right kidney, and CCT abdomen showed RCC right kidney, sir. This is the lesion, right kidney. RCC.
What do you mean RCC?
Renal cell
Carcinoma.
carcinoma.
Renal cell carcinoma. Okay.
And they done referred the patient to urologist, sir. They done right radical nephrectomy, and biopsy done showed a clear cell renal cell carcinoma, sir.
Okay. So what are you postulating?
Sir, it may actually some studies I have searched, sir. They showing there is a chance of a paraneoplastic myelopathy in case of a renal cell carcinoma, sir. So whether we can include this also as our third diagnosis, whether paraneoplastic myelopathy as third diagnosis of this.
Only for the presentation.
Present, only for the
not
present.
for the
Sir.
past.
Not for the past, sir, only for the present.
So you will have to relate it to the past also.
Yes, sir.
I would take it as an incidental thing.
Were you able to show oligoclonal blanks
Sir,
in the
actually,
CSF?
investigations are not available, so we didn't do, sir.
I would consider this RCC as something that's incidentally found on the MRI. I would be hesitate to relate that to a disease that's going on for 20 years. The second thing is I would definitely want to rule out Sjogren's syndrome, the myeloradiculopathy like this.
What about MOG and NMO? Were they done?
No, sir, no, sir. Actually, patient
Okay.
immediately
So,
referred the
so we
patient
do
for
not
surgery,
have all
sir.
those. Right, fine. Okay.
Immediately referred for surgery. They done surgery within a week, sir.
So it's a presenting units diagnosis. Oh, longitudinal extensive first presentation. Okay. Go ahead with that. Whatever you wanted to show, go ahead with that.
These are some studies I have read, sir, that about some longitudinal extensive myelitis as a first presentation of RCC. These are other studies in Bangalore done, sir. Longitudinal extensive myelitis with echoporin 4 antibody positive in renal cell carcinoma.
Oh. But they were all after, I mean, in the time frame, temporal profile, how long was the LET presented earlier than RCC?
Sir, actually, they only work in these two cases. After working up only, they came to know RCC, sir. Nearly 1 month duration on working up.
That's all. That's all.
RCC,
okay.
sir.
Okay. So that is why Shivakumar was saying this could be a different episode and the past being different episodes. Is it? Is that what you had in mind, Shivakumar?
No, sir. Just I asked whether such a long period of asymptomatic period can exist, but I also believe that this is a autoimmune disorder with NMOSD, and that RCC is an incidental. That's what I also believe, sir. But just I asked for whether such a long asymptomatic period can happen in a case of.
Why NMOSD with 17 years, 20 years? Why NMOSD? MS is more likely, isn't it, with 20 years duration? Except for the imaging finding of LETM.
Imagine we see the longitudinal involvement in the spinal cord, sir, which is unlikely in an MS. That is a reason.
Less likely, yes. Less likely. But the other features, what you see in the brain, which was seen earlier.
Previous reports are suggestive of MS, sir, but the present reports, it is suggestive of NMOSD.
So if there are, sir, I think if we are looking at NMO and MS after the MRI, basic question is, does it satisfy the criteria?
Sorry, there was a disturbance.
Sorry, sir. The basic question is, now that after the discussion is after the MRI, whether the lesions satisfy the criteria for MS. If there are lesions that are classical of MS, we should not be considering NMO. That is a basic criteria in NMO too. There can be brain lesion, but that should not be typical of MS.
I think we should have the antibody studies. That is the one thing
we should do that.
Settle the issues. Yeah,
we should.
Sir, I think antibodies are negative. Can you just rule out NMOSD? That is the problem, sir.
As we are talking,
NMOSD
less likely, more. We are talking of less likely, more likely, unlikely. Yes, less likely.
There are 4 entities they have mentioned. One is that NMOSD positive, negative, as well as
both seronegative.
Positive.
Yeah. Agreed.
Both MOG and as well as NMOSD positive.
Yeah, seropositive, seronegative, both seronegative. Yes, all that is mentioned. Of course, yes. But we'll have to come to some conclusion, no? And anyway, what is the treatment that you are giving now?
Sir, actually, we have initially given for steroids and rituximab we have given, sir. After that, patient showed some improvement, sir. Means he started to walk and his power also improved. And after that, we referred the patient to urology, sir. They done surgery, and after time of discharge, patient was fully all right, sir. He was walking. His power is nearly 4/5 pounds.
Okay, we are still nowhere. But I think some clue, some lead might come from the antibody studies. You have to do OCDs as well as NMO and MOG. It doesn't
not to forget DNA profile also.
Okay.
Sir, the problem is that since we are in a government hospital, there's a difficulty in getting all these things done.
Sir,
I understand.
So, are you not surprised when you see the VEP, which is normal? Even at the time when the patient was blind or when the patient was having impaired vision, and after that also when you suspect multiple sclerosis, VEP will definitely give us a clue.
Meghandan sir, VEP was not done when the patient had a visual symptom, and after the visual symptom, VEP has not been done. It was before that.
No, she said VEP was normal somewhere.
That was before the visual symptom. That was in 2002, the first episode of neurologic deficit. It was in 2005 that he had visual deficit. After that, VEP has not been done.
Now, at least when you suspect NMO and
I think
Normal,
now she said it is
Normal.
normal.
no other.
Sivakumar,
Sir, yes, sir. What you said is correct, sir. That
you would have some of these chief minister scheme where insurance patients money would be there in the department. You can spend that to do at least one of these antibodies.
Some patients we are doing, sir, but not every patient we could be able to do it.
No, but for this patient, academic
This
interest,
patient will do it, sir.
You can even write academic interest and get it sanctioned from the dean and do it.
Yes, sir. We'll do it for this patient. We are doing it, sir, but not for every patient. We are doing.
No, I'm talking of this patient only.
We will do it, sir. We'll do it, sir. We'll do it, sir. Then next we will present the next meeting.
Okay, thank you.
Sir, I think I'll put my money behind renal cell carcinoma and paraneoplastic syndrome in this case, as the presenting unit also described.
That is for the present.
After going back.
That is for the present episode.
Yes, sir. Yes, sir.
Past.
So
it's a very nice case, eye opener. I have never come across such a, or I never knew.
For all of us.
Vijayan, the eye opener will always be the MRI. You screen the spinal cord, you'll find the RCC. That's not the problem. They don't have to do anything extra.
Some doubt, sir. Is the present problem separate paraneoplasty due to RCC? That is a MS. Previous problems are MS. The present problem is paraneoplasty. Can you take it as?
Yes, sir. As Professor Yomas pointed out, the MRI picture is not that of MS. Very clear. I think this is RCC paraneoplastic.
The present MRI. The present MRI.
Now, in this article, what do they mention about this presence of renal cell carcinoma with excessive?
The topic is very revealing, sir. That reveals their mind. They say association only. They have not mentioned as a paraneoplastic manifestation.
They have not mentioned anything about it.
No. I think it is. I think if I read that, we would have to read that article. But they only said an incidental LETM in renal cell carcinoma.
And because they have mentioned acoparin 4 antibody positivity in renal cell carcinoma.
Sir, and aquaporin antibody and come back to ANA are co-positive in many patients.
UMS.
They have not mentioned
UMS.
Sir.
I think you would agree that longitudinal extensive, not transverse, myelopathy picture on MRI has been mentioned, has been noted in MS also. And here,
yes, sir, it is, sir. Yes,
yeah,
sir.
And here the clinical picture was not a longitudinal transverse myelopathy picture. It was more of a brown sequard-like presentation.
Sir, I know it would be very difficult. We'll have to see the VEP, amplitude, intensity, or maybe the waveform. But I would
so we are not sure.
Normal, no, sir. My only thing was just going by, like we do in the Wednesday, going by what has been given. The VEP being normal after so many episodes is, and the dramatic response to steroid, they say patient went walking. Sir, that happens with Jogren, sir. I have had longitudinal, personal experience is always clouded thinking, but I've seen patients walking normal. After steroids, especially, they respond very well.
So if it is Jogren, again, it is not an NMOST.
It is not an NMOST.
That's what. My point was regarding NMOST. Okay.
No, sir, it is not an NMOST.
Jogren's maybe, yes. Jogren possible. Jogren,
the radiculopathy too. Sir, with the prominent radiculopathy
too. Jogren, Sivakumar.
Yes, sir. Simple.
That should be possible.
Pro and la, yeah.
Okay. Allegation, sir. Again, back to you. Allegation? Allegation, are you there?
Audible?
Yes, sir. Can you proceed?
Okay, sir. Thank you, Dr. Krishnapriya, for your excellent presentation and your interesting case. We'll move on to the last case.
Thank you, sir.
I invite Dr. Suresh to present an interesting case of recurrent myelopathy.
Good afternoon, sir. Today we will present a case of recurrent myelopathy. This case history, this woman, Satyajodi, 29 years, she is a diploma nurse, right-handed individual. And present she was a homemaker. She is coming from Edapadi. Chief complaints was difficulty in using left upper limb and lower limb for 5 days, and the complete loss of vision on her left eye for 5 days. The patient was apparently asymptomatic 5 days before this admission, and she got inability to use left upper limb and lower limb for 5 days. It was slow onset and progressive in nature. Initially, it was difficulty started in her left upper limb and lower limb, which was noticed, and she feels that her limbs were stiff also. Difficulty in reaching objects above her head using her left upper limb, and she also has difficulty in holding objects in the left hand. And she has difficulty in getting up from the sitting position, and she also has difficulty in wearing chappals and also walking with chappals on left lower limb. Her weakness worsened within 2 days, and she needed support for activity of daily living, and the weakness was static after second day. And no history of any thinning of limbs, no history of difficulty in turning side to side on bed. And she also had a complete loss of vision on her left eye. It was painless. It was started along with her limb weakness from day one, and it is a complete loss of vision on your left eye, but the right eye vision was normal. No history suggestive of any other cranial involvement. She is able to perceive, appreciate smell, able to look around all directions, no history of drooping of eyelids or double vision, able to feel sensation of face and chew foods, able to drink or eat well, with no drooling of saliva or no nasal regurgitation, able to speak well, hear well, and no tinnitus or giddiness. No history of any numbness of limbs, and she is able to perceive cloth and heart and water sensation. No history of bowel or bladder involvement, no history of any memory loss or ultrasensory or any abnormal behavior, no history of any headache, seizures or vomiting, or slurring of speech, or fever or neck pain, no history of any abnormal movements, no history of any trauma, no history of any multiple joint pains, oral ulcers, or skin rashes or dryness of eyes or mouth. Past history, she had admissions 3 months before this illness, and that was happened 3 months postpartum period. It was a bilateral lower limb weakness with also with numbness below hip in both lower limbs, and she also had urinary retention. It was in July 2022, and for which she was admitted in the hospital and she was discharged after 7 days after this hospitalization, and she recovered completely and was discharged with oral drugs, and she was apparently normal and doing her routine activities without any residual weakness, but she stopped drugs after 1 month after discharge, and she lost follow-up. No history of any recent vaccination or doctor, no history of any radiation therapy. She consumed a mixed diet, normal, bowel and bladder happy this time. Sleep and appetite was normal. Born out of non-consanguineous marriage, 2 siblings, both were normal, and no significant illness, similar illness in the family members. Her menstrual cycles are normal, and she is postmortem now around 8 months post-delivery. Summary, this 26-year female with left upper limb and lower limb stiff weakness, both the proximal and distal, with a subacute onset and progressive with associated left eye complete loss of vision, with no sensory or cerebellar, no bladder involvement or any other cranial involvement, with the significant past history of bilateral lower limb weakness, with the sensory and bladder involvement at that time. It was treated and improved 6 months back. So, as per history, this time the structure involved is left second cranial nerve with the loss of vision and corticospinal tract above C5.
Okay, what are the possibilities?
With this recurrent neurological illness and with involving left upper limb and lower limb with vision, so it must be a demyelination disorder with first possibility of NMS concern, and second multiple sclerosis, and still anti-MOG antibodies also.
Okay. Proceed to examination findings.
General examination, conscious oriented to time, place, and person, afebrile. No pallid icterus cyanosis, clubbing pedal edema, lymphadenopathy. No neurocutaneous markers, no peripheral nerve thickening. Pulse rate was normal, BP was 110/70. Respiratory rate was 14 per minute. CNS examination, higher mental function was normal. MMC was 27/30. Cranial nerves, first cranial was normal. Second cranial nerve, there is a loss of direct reflex on the left side with relative apparent pupillary defect with loss of only light perception on the left side, and the field of vision could not be assessed, color vision could not be assessed on the left side. But the right eye is normal except for the indirect right reflex. Visual acuity was normal, field of vision, color vision was normal. Fundus was normal on both sides. Other cranial nerves are normal, including facial nerve and trigeminal nerves. So spinomotor examination, bulk of the muscles are normal. Tone, we can see the increased tone on the left upper limb and also in the left lower limb. Power, right side of it was normal. In the upper limb left, there is flexion is 2/5, extension was 1/5 in the shoulder joint, and abduction was 2/5, adduction was 1/5. In the elbow joint, it is 2/5 flexion, extension is 1/5. This joint is 0/5 on the left side, and the cambric was weak on the left side. In the lower limb, right side was normal power. With the left side, hip flexion was 2/5, extension was 3/5, adduction was 3/5, abduction was 2/5, flexion was 2/5 in the knee joint, and extension was 3/5 in the knee joint. Ankle joint, only the plantar flexion is 1/5, other dorsiflexion, inversion, eversion is 0/5. Toe movement could not be done on the left lower. Reflexes, superficial reflexes, corneal, conjunctival, palatal, gag reflexes normal. Abdominal reflex was absent on both sides. Plantar was extremes are bilateral. Jaw jerk is not elicitable. Other deep tendon reflexes, biceps, triceps, supinator, knee, and ankle are brisk. Sensory examination was touch, pain, temperature normal. Joint position and the vibration was normal. Convulsion could not be elicited. Coordination was normal on the right side, left side could not be performed. Stance gait could not be assessed. No signs of any autonomical dysfunction, no hints of meningeal irritation. Spine, cranial was normal. Other systems were normal. So after examination, this summary of 26-year female with subacute onset and progressive weakness of left upper limb and lower limb, both proximal and distal, with distal more than proximal, with bilateral brisk reflexes, with both plantar extensor, with left eye complete loss of vision, which was painless, and no other cranial involvement, and no sensory or no cerebellar, no bladder bowel involvement. With the past history of bilateral lower limb weakness, it was associated with the sensory and bladder involvement, and was treated and recovered completely. So the structures involved is left second cranial involvement with bilateral corticospinal tract because of the exaggerated reflex on the other side, with the motor level above C5 and reflex level above C5.
Right, after the examination, the possible diagnosis.
So again, the demyelination disorders with NMS may be the first option. Second, still multiple sclerosis and MOG antibody positive also positive. And rare possibility of vasculitis also. Female.
Okay. So any other discussion, comments from others?
I think he can proceed. Let's see what.
Okay. Okay. Proceed with the investigations.
Routine investigation was normal. VCD was not there. VCD and HCV negative. SSC was normal. CT brain was normal. And the CSF analysis was clear fluid with WBC count raised 44, with lymphocyte 61, polymorphs at 39%, and RBC count was nil. Protein was raised 116 milligram, and glucose was normal 56 milligram. This was the past previous MRI, brain and also the spine. There we can find a small focus of diffuse restriction in the mid-stream of corpus callosum and long segment in the T2 player in the cord hypertension seen in cervical cord from C3 vertebrae extending to cervicomedullary junction and posterior medulla. And this long segment involved from C6 to D10 levels. Suggestive of D1 lens. And this time, this December 12, we can find this hyperintensities seen on the cervical cord and with mild cord enlargement also. And this cord expansion with long segments, inframedullary hyperintensity noted from C7 to T1 level with more than 2/3 involvement of the cord. So VP was normal on the right side. Left side it was not stimulated. Anti-enema antibody was positive and the anti-MOG antibody is negative. So the diagnosis NMSOD with aquaporin IgG positive. And treatment given as IV methylpred given for 1 gram per day for 5 doses. And rituximab was given 2 doses, each given at 2 weeks apart.
What was the response?
So this time power improved a little, sir, from 1/5 to 2/5, but still she could not walk without support for walking, sir. The power improved until 3/5. Upper limit is 2/5. And vision not improved. It was a complete loss of it, even after the time of discharge.
Okay. Can you please mute? Yes, through Ashok Kumar.
One thing is, this is a straightforward case of NMOSD, sir. Only thing is that how long we have to give treatment for this, because she is a young lady and likely to have a recurrences in future also. And how long to give treatment, and either rituximab alone is sufficient, or whether we have to go for other immune modulated drugs. And what is the long-term side effects of rituximab when we keep on giving every 6 months? These are the questions there in my mind. Just I'm asking the forum, and with their experience of treating NMOSD for a long time, and what is the outcome in these cases?
I think all of us would agree that for a given patient, it is very difficult to predict the long-term outcome. Each person, it will vary. And as far as, of course, Vijayan is the one who has a lot of experience with rituximab for a long time. But there is no harm in continuing rituximab, provided we have the counts done periodically and provided we see to that there is no infection associated. Being young, she should respond well to, she should not have problems. She should tolerate rituximab well. And mostly we would be giving it not for further improvement, probably to prevent any recurrence. But improvement, I do not know how often with repeated doses improvement sustains. Even otherwise, if there is going to be an improvement, it would be there. Maybe others can say their views on it and their experience.
Sir, Vijayan sir, are you in line, sir?
Sir, I am there. But
what is your experience with treating such cases? Because I have been seeing that you are treating more cases of you are treating NMOSD. What is your experience of recurrence and then the treatment of recurrence for these cases?
I put them on, I treat them aggressively with rituximab, sir. We give 4 doses of rituximab. And then after that, most of the times I place them on mycophenolate mofetil, oral mycophenolate mofetil. After about 1 or 2 months after the rituximab, second dose of rituximab is over, I place them on mycophenolate mofetil and then continue on mycophenolate mofetil. Only if there is a relapse, then I do consider second dose of following dose of rituximab. Otherwise, I don't give rituximab on a regular basis, only to attain the first remission. After the first remission is achieved, I place all these patients on mycophenolate.
Vijayan, the question was with regards to inadequate remission or continuance of neurologic deficit, whether you would repeat Rituxi, and if so, for how long? And what is the response to Rituxi? Do patients, all of them, do they improve? Or if they improve, how much do they improve? That is what Sivakumar wants.
All of them definitely do not improve, sir.
Yes.
Definitely all of them do not. I don't have data with me, but all of them definitely do not improve. If they do not respond to rituximab, I think we should try also plasma exchange.
That's a one-time measure, sir, but we have to keep on doing each time when the patient gets the symptoms.
Yes, sir, I agree. Only to tide over the crisis, to do the plasma exchange. And if the patient gets better, then we place on mycophenolate mofetil for the longer, to prevent the relapse.
What if they do not get better? That's what I think. That's what I understood from Sivakumar's question.
What if they do not get better? Rituximab
what
and then plasmapheresis, or plasmapheresis and rituximab either.
Mycophenolate mofetil, sir, whether it's able to prevent relapses in future, sir. That is whether the further relapses is it preventing, sir.
Yeah, that is why it's given. Azathioprine and mycophenolate is given only for that reason.
Whether that prevents, whether that's 100% prevents recurrence of future recurrences.
No, it does not prevent 100%.
Nothing is 100%.
Suppose if you get a lesion with in the recurrence with the mycophenolate mofetil, what will you do, sir? That is the question.
If there is recurrence on mycophenolate mofetil, I restart them on rituximab or try Plex again. That is the only modus operandi. Otherwise, nothing else.
Okay, sir. Thank you,
sir.
And
Dr. Duraraj from Madurai. Any role of IV cyclophosphamide?
Yes, of course. There is a role. Yes.
Actually, if the patient is not affordable, I am using cyclophosphamide for 2 or 3 patients.
Yes, Durai, that is also another option. Yes, you can try, particularly with you can try a pulse dose if the patient is not improving with Rituxi. Yes.
Sir,
all that has been mentioned. Yes.
So is it that it is our preference of going for immunosuppression, whatever the drug we prefer, or is there any standard guideline? Which drug has to be used first, then next what? Is it anything graded guidelines is there available?
Say compared between Rituxi and cyclophosphamide, everybody uses Rituxi. But if there is no adequate response to Rituxi, and if you want to try, you can give pulse dose cyclophosphamide. Whether the patient improves on this, we do not know. Now, I mean, nobody can say with any certainty with regards to all these medicines. But all of these medicines have been tried. If something doesn't work, you go to the next one.
It's a trial and error method, sir. That's what we are.
Absolutely. We do not know which drug works for whom. Till we have genomic availability, we do not know which drug works for whom.
And
Sir, I think even the
consensus
guidelines, even in the consensus guidelines, it was left to voting to decide whether and the experts panel, I think they voted for rituximab. 8 out of 10, I forgot. I don't remember. I think I have to go back and check.
Yeah,
it was only left
yes, of course.
It was left out to voting. There was no randomized control trial proving one better than the other. But the expert committee, it was left to voting only. 8 out of 10 or 7 out of 10 voted for rituximab. That's all.
Durai wanted to say something. Durai?
Actually, the patient's economy decides the treatment rather than the many times. My personal feeling. And if you
exactly, sir, agreed.
They will run away from us.
No, you certainly have to consider that. No questions about that. Yes. And yes, pulse cyclophosphamide has helped in several of these autoimmune conditions where others have not helped. But whether it's a certain improvement, we do not know. But of course, worth trying. As you said, because it's not expensive, under monitoring, it can be tried. Shivkumar,
Yes, sir.
see, in this patient, you have done a NMO antibody.
Yes, we are doing it, sir. We are doing for some patients we are doing it. Some patients we are not able to get it done that
that's
time.
right.
That's it.
Okay.
We are doing it, sir.
Okay. Good. I wanted to ask Vijay. Vijay, I wanted to ask one question again. You said if they have a relapse with mycophenolate, you will go on to rituximab. I just
Yes, sir.
wanted to know how many of your patients on double M, went on for relapse.
Very few. I would say less than 5%, sir. Less than 5%.
Okay. So generally, double M works.
It works, sir. It works.
Yeah, generally itself, the relapse is not that common. Even if you.
Yes, sir. It works. Yeah. As you said, the relapse is not that common also. Yeah. While on MMF, I have not seen much of relapses.
Okay.
It
Thank
works.
you. Thank you.
Any other comments from anybody else? I think there's no more comment. I thank the doctor for presenting this wonderful case.
All the cases.
All the 4 cases. I thank the 2 moderators, Professor Sivakumar and Professor Thiruvachilan, for their wonderful cooperation. Thank you, sir.
I thank, apart from the presenters and the moderators, I thank Professor Alagasan for chairing the session. Thank you, Alagasan.
Thank you.
We would like to see you again.
So I thank Professor Vian. Sir, Professor Vian for organizing such a wonderful lecture.
No. See, this is
and
a
inviting us to present the cases.
Thank you for coming forward to present, and thank you for your PG. Oh, your PGs did a very good presentation. That shows the level of training which you give. It's very nice to hear them present so well. Thank you, Shiva, and thank you, Thiru.
Thank you.
Still, your teaching is still excellent.
Forget me. You continue with the job.
So I thank Professor UMS. We expect a lot from Professor UMS. I think he should come forward in teaching for us regularly.
I do not think he is there now.
Okay, sir. Thank you.
Thank you. Thank you all.
Thank you, sir. Thank you, sir.
Thank you so much. Thank you. And thanks to Sun Pharma for once again being with us and organizing this. Thank you, Sun. Is Palni there? Who is there with on behalf of Palni? No, it's
Shafiq Muhammad is there, sir. Thank you, sir.
Oh, Shafiq, yes. Thank you. Thank you.
Thanks a lot, sir. Thanks a lot, sir.
Thank you so much. Thank you very much. Hello. And incidentally, next month it will be pediatric neurology. Professor Maya Thomas has agreed to present cases from CMC Vellore, and it will be pediatric.
Sir. This week I will get the details, sir.
Okay.
Yes, sir. Yes, sir. Thank you, sir.
Okay.
Thank you, sir.
Thank you.
The first time came in our class.
Monthly Sunday.
Thank you, sir.
Thiru.
Yes, sir. I am.
Shiva also. Okay. Next month it will be pediatric neurology from CMC Vellore.
We will participate.
And hopefully Professor G. Kumaresan is here and he has agreed to chair the session.
Yes, sir. We will participate, sir. We will eagerly
Thank you.
participate and ask
Thank
our
you.
postgraduate also to attend.
Thank you all.
Thank you.
Thank you, son.
Thank you, sir.
Thank you, son. Sun Pharma, thank you.
Thank you, sir. Thank you. Thank you so much, sir.
Right.